I'd like to welcome the audience today for this very excellent discussion I have with two of my colleagues, an oncologist and a cardiologist. And we will be talking about how to assess and manage breast cancer patients when there's a fall in their systolic function. So I'm very honored today to be with, as I mentioned, an oncologist and a cardiologist. I've got from the oncology side, one of the breast cancer specialists at University of London Hospital, Dr. Elisavet Papadimitraki, and I also from the cardiology side, I'm very privileged to have Dr. Rebecca Dobson, a consultant cardiologist at Liverpool Heart and Chest Hospital. So welcome to you both.
Hi.
Thank you.
So if I could maybe start just with you, Elsa, if you could lay the scene for the audience. I mean, I know that we do get referred a number of these patients, but some of them are at the beginning of treatment, some of them are, some way down the treatment. And of course, there are differences in terms of metastatic, non-metastatic, and whether they're planned for other treatments, such as, is it anthracyclines that's caused it? Is it HER2 therapy? Some are planned for surgery. So I think a wide range of different patients. So maybe if you could just give us an idea of the types of patients, what you do, when are you worried, and how you manage this situation.
Yes, thank you, Arjun. So as you're saying, the breast cancer management involves drugs which are related with cardiotoxicity, mainly the anthracyclines and the anti-HER2 agents. I mean, both drugs are really important in the management of both early and metastatic breast cancer. And there is some protocol and recommendations in regards to the management or the monitoring of the cardiotoxicity from the HER2 agents, but it's not very much a consensus about the monitoring for the anthracyclines. So as you're saying, part of the assessment for every patient is not just the breast cancer itself, but also, and the risk associated with that, but also the benefit from the treatment in balance with the anticipated toxicity. So the assessment when we see a patient either with, especially with early breast cancer, which is potentially curable disease, so the threshold to accept side effects is obviously higher, is really to understand what is the underlying what are the underlying medical conditions that may increase the anticipated toxicity. So other factors such as hypertension, underlying heart disease, older age, valvular, other, all heart-related diseases, obviously are taken into account before we suggest any treatment. In the metastatic setting, things are a little bit different because in the metastatic setting, the battle is a little bit, at a different really perspective, because the metastatic breast cancer can be potentially life-threatening. So every treatment will have some side effects, but it needs to be balanced with the toxicity or the anticipated outcome because of the breast cancer. So it is different when we explain or when we consider the toxicity for early breast cancer, where we want to maximize all the potential benefit without jeopardizing the long-term safety. And it's different when we take into account the battle with metastatic disease, which could be potentially life-threatening. So when we see patients for early breast cancer, usually the drugs we use for the adjuvant or the neoadjuvant setting, so either before the surgery or after the surgery, we usually do this baseline assessment, and when the treatment includes anthracyclines or HER2 positive or HER2 agents, such as Herceptin or pertuzumab or TDM1, we always include a baseline echo. Now, in most institutions, we do an echo. In some others, it could be a MEGA, for example. That really depends on, the capacity of every institution. But a baseline assessment is required for the anti-HER2. And some oncologists, including myself, we also do it before the anthracyclines. So that is for the early breast cancer. And then when the patients continue with the anti-HER2 agents, which is usually for 1 year in the early setting, we do it every 4 months. And that is the standard if there is no toxicity, additional toxicity. If there is toxicity, and we will discuss obviously about it, then a different pathway is initiated with a referral to the cardio-oncology service. And we have the luxury to have you and your team at the UCLH, which really makes things easier and excellent for the patients. But the landscape is really that every time we see either a subclinical drop in the ejection fraction in the regular echo, or whenever we have clinical concern, we refer the patients. And even I think, we are discussing also the guidelines in terms of whether it should be the referral when there is a clinical drop, but still it is above the 50% of the ejection fraction, or whether we need to do it only if it is clinically significant or if it is below the normal. As I said, in the metastatic setting, things are a little bit different. We are still very vigilant. We still remain very vigilant about any toxicity, because we know that this is a treatment which is very important, and it changes really the natural history of the HER2 positive, specifically breast cancer. The anti-HER2 therapy, the first drug, the Herceptin, has changed really changed the natural history by decreasing the possibility of breast cancer relapse and death by 40%. So, it is a great benefit, and the patients rely on this treatment for a very favorable outcome, which is measured in years with good life. So it is fundamental in the metastatic setting also to be able to continue treating the patients. And that's why optimizing the cardio protection is really important for us.
Okay, thanks so much.
I think that's the summary, and then we can go a little bit more.
Sure. No, absolutely. I think that's a very, very nice kind of introduction, baseline understanding of the different groups of the patients. And I guess just to kind of touch on some of the things that you've mentioned, and this is a question to Rebecca. What are your thoughts from a cardiovascular perspective? And I suppose this is both at a service level and also at a clinical level, of baseline screening. Elsa talked about screening all the patients for HER2 therapy, and she personally does screen anthracyclines, but not necessarily everyone. And I know that different guidelines say different things. So from a cardiological perspective, Rebecca, did you have any kind of comments on that?
Yeah, so in an ideal world, I completely agree. We should be baseline screening patients pre-anthracyclines, then again post-anthracycline before they start their trastuzumab or whichever HER2 directed therapy they're having, because down the line we know if patients then develop a drop in their ejection fraction or a deterioration in their strain, it's really difficult to unpick what's causing it if you don't have a baseline after the anthracyclines, because most of these patients, I'm sure you'll correct me if I'm wrong, but most of these patients will have received anthracyclines. About 80% will have done, and we know that the anthracyclines can cause toxicity, delayed toxicity. So having a baseline assessment pre and post anthracyclines before you start HER2 directed therapy, I think is very useful. But we're all working within the NHS, and we're all working with very overstretched and under-resourced echo departments, and sometimes there has to be you have to make a decision based on how you can treat or how you can screen the most people. So certainly locally, our cardio-oncology service doesn't get involved with baseline screening unless there's a high-risk patient who the oncologist would like to be optimized from a cardiovascular point of view before they start therapy, and then we will perform the baseline screen and all the subsequent screens. But aside from that particular group of patients, all of that screening should occur locally.
Okay, and I think, Elsa, you also touched upon surveillance in general. Once they're on the therapy, every 4 months or so, depending upon different guidelines. I mean, we will, of course, after this be touching upon cases where there's a fall and what we do in that situation. But maybe if I could just ask you, there's some debate, I think, especially among oncologists and maybe even among cardiologists, that it's too much or too frequent screening, and if everything is fine, is it okay? And I know that these are the FDA guidelines, and that was kind of what was there in the trials, and it's really kind of evolved from that. But I mean, are your thoughts, do you have any kind of comments on that matter? Maybe Elsa, if I could start with you.
Yes, I know. I'm aware, obviously, of the debate. And, frequently we do discuss this in the practice, because we get a call from the pharmacist, oh, this patient didn't have, she's on this treatment for 4 years. She didn't have the echo the last week as we was expected. Shall we continue with the treatment or not? And I think in the metastatic setting, again, when you have patients who never had any clinical or subclinical toxicity, that 4-monthly echo is probably too much, is not necessary. Because first of all, the toxicity seems to appear at some point. It could be early on, not necessarily after many years of treatment. And second, I think, again, in the metastatic setting, we are talking about a very essential therapy. So some drops which will not affect the outcome of the patient will not be so detrimental, and therefore there is no point to just really chase up so closely. And the truth is, in reality, we haven't seen that much toxicity. When we see the patients, as you know, Arjun, sometimes you see toxicity when you don't expect it in very young women. And you don't see any toxicity in women older who have been on anti-hormonal or anti-HER2 therapy for a long time. So I think it's not very clear. And, I would really support that we don't need to do the echo every 4 months for the metastatic setting. And different hospitals also can have quite different approach. The Royal Marsden, for example, we used to have the echo. I mean, we're doing mega there, but every 6 months for the metastatic setting and every 4 months for the adjuvant, which makes more sense, really. So I think that's for the separate settings.
Sure. And I don't know, Rebecca, if you have any comments regarding this.
Yeah, it's difficult, isn't it? Because I think we all, doctors and patients, we like to have a clear protocol. We like to have a clear plan of, okay, we're going to do this, and then in 3 or 4 months' time, we're going to repeat it. But I think we need to move away from having a one-size-fits-all approach. Yes, there's definitely differences between metastatic and non-metastatic patients, but also I think, as we've touched on, in terms of the patient risk, I think your baseline risk assessment is really important here to help you decide what is the most appropriate frequency of screening. So if you've got someone who is low risk, they've had no previous cardiotoxicity, no cardiovascular problems, I completely agree with. I think we probably are overscanning these patients. And as has already been said, particularly the metastatic patients, the benefit to these patients for continuing their Herceptin far outweighs the risk of a drop of a couple of points in an ejection fraction. However, I think patients with medium to high risk, and we can talk a bit about how we think about risk, but patients at a higher risk of cardiotoxicity, I feel that we should be scanning them more frequently than the lower risk patients. So whether that's every 3 cycles or every 2 cycles, and then tailoring off if the patient remains stable. It's a pretty evidence-free zone. And I think if you read 10 different guidelines, you'll get 10 different opinions on how it's best performed.
Sure. And Elsa, if I could ask, how common actually is this in your experience? And you obviously see a number of these patients. This is your main focus area. Is this common? And drops in ejection fraction or changes in GLS? And what do you do in that situation?
Okay, so it's not common. It happens, though, in the clinical practice, it does happen. And I think all the oncologists dealing with breast cancer come across this. So what we do, so first of all, if there is drop less than 10%, we usually monitor, and still above the normal, we just monitor. If there is more than 10%, and then we take some measures. So maybe referral to the cardio-oncology for optimization, earlier echo, maybe start treatment. We will be guided by the the cardiologist on that. If it is more significant, then definitely we will delay the treatment, and referral will be made to the cardio-oncology clinic. Because we have such a close cooperation, we usually start also the treatment, some cardioprotective drugs, AC inhibitor or beta blocker, low dose. And by the time they may see the cardiologist, they may be able to have it a few weeks, so, they can start. We had some quite challenging cases, as you know, with young patients who drop significantly the ejection fraction out of nowhere. And I think for me, this is the most alarming thing, because we're talking about curative disease. We're talking about patients who have many years of life. And the ejection fraction drop, for example, could be from 70% at baseline before the anthracyclines, before anything, to 44% after the anthracyclines and some anti-HER2 therapy. And then you have to give more 14 cycles of the treatment in order to complete the whole adjuvant setting, therapy. And for these patients, we have been very intensive in the monitoring with cardiac markers before each cycle, troponin, PNT, and ejection fraction prior to each cycle. And we managed to have almost complete resolution of the toxicity. And the patient is very well. But I think this is the most alarming case for all the oncologists.
Sure. So, Rebecca, I guess maybe two groups of patients that Elsa's described. One is when there's a fall, maybe not a major fall, 10 to 15%, maybe within the baseline, or maybe still within more than 50%. And then there's the second group of patients where there's a bit more of a dramatic, big change. So if I could ask you, as the cardio-oncologist, when these two different types of patients are referred to you, what is your management strategy, and do any guidelines have a role to play in helping you?
Yeah. Thanks. There's a lot to say there. I'd say the first thing is the cardio-oncologist has to be confident that the drop in ejection fraction is real, because we know that ejection fraction on its own is a pretty crude measure of LV systolic function, particularly 2D ejection fraction. So the variability of your ejection fraction, if you measure my ejection fraction today and you measure it again tomorrow, it might vary by up to sort of 9-10%, and it doesn't mean that I've suddenly developed heart failure. So the first thing I'd say is that a really in-depth assessment of the patient's cardiac function is crucial. So that would include, if possible, 2D and 3D LVEF measurement, plus, as you've mentioned, global longitudinal strain. And then if you're confident that you are seeing a true drop in ejection fraction, then I agree. If you've got a relatively small drop that is the LVEF is still greater than 40%, I would be very loath to discontinue Herceptin. there's not a lot of data on this. We've got a bit of data from the Safe Heart trial. Yes, it was a small trial, but that was looking at a group of patients with stage 1 to 4 breast cancer who all had an ejection fraction less than 50%. I think it was 40 to 49, correct me if I'm wrong.
Yeah.
So yeah, about 30 patients in that study who all continued their Herceptin despite having a low baseline ejection fraction. And out of the 30 patients, I think 3 developed a cardiac event, and 2 had a cardiac event and 1 had an asymptomatic drop in ejection fraction. So it gives us a little bit of room to maneuver with this group of patients, because as a cardio-oncologist, I'm very mindful that my role is not to put up any barrier to oncology treatment. And clearly there are times when that has to happen and you have to say, I'm sorry, this patient cannot have any more. But I see my role as trying to facilitate uninterrupted chemotherapy or Herceptin therapy. So in that group of patients, I would monitor them closely. Certainly I would increase the frequency of monitoring from, say, 3 months to probably either every other cycle, or perhaps every second cycle. But usually if there's been a drop, I would scan them again within 3 weeks. And as Elsa said, we'd be wanting to institute ACE inhibitor or ARB antagonist plus minus a beta blocker at an early stage. But I would really try hard not to interrupt the Herceptin in that group of patients.
Yeah. And I guess then for the other group, when there's a big fall and the Herceptin has already been held by the oncologist because there is such a big drop, apart from, say, the ACE and the beta blocker, anything else? And how easy is it to actually at some point restart the Herceptin, or is that very difficult?
No, I think it's getting easier. Historically, I think a lot of patients had their Herceptin stopped and that was it, game over. They weren't given any more. And I think we probably did those patients a disservice. And now what I would say, I frequently get referrals where the oncologist has identified a drop in ejection fraction. They've quite rightfully started an ACE inhibitor plus minus a beta blocker. And then I've seen the patient maybe a week or 2 later, and actually the ejection fraction is already starting to improve. So I think getting in early with cardioprotective medication is important. And I think we are all getting better at re-challenging these patients. And as Elsa said, most patients who you re-challenge will be able to tolerate their Herceptin as long as they are on cardioprotective medication and are clearly closely monitored. It's actually quite rare, I think, that we've not been able to restart Herceptin. Yes, there's the odd case, but usually the ejection fraction will improve. In answer to, is there anything else you can do for these patients? Well, standard heart failure treatment. So if you've got someone who's still got impaired ejection fraction on an ACE and a beta blocker, I would add in a mineralocorticoid antagonist as well.
Sure. And is there any value of ejection fraction or GLS at which point you say, well, actually, I think we need to stop now? Or is it really a combination of that and biomarkers and symptoms and of course, prognosis? And maybe if I could ask Elsa that question first, I mean, would you just go by whatever the cardiologist says and trust them, or say that, no, this is just too high risk?
Well, I mean, Rebecca, she's right. I mean, the help from the cardiologist is enormous, because we get the feeling that they really want to remove the barriers for the patients to have the best possible treatment. And that is very helpful, because we are exactly on the same page. So that's the one. The second is that the majority of the patients will be able to continue the treatment without problems, taking the medication. There are a few still exist that even if you reintroduce the Herceptin, will drop again. And again, a smaller percentage will develop symptoms of heart failure. So it's really rare, and it's becoming more rare as we have this optimal treatment. And as you said, the most important is that these patients move from a condition where every drop meant stop of the treatment, or every significant drop meant actually stop of the treatment, while now we are able to continue the therapy, and that is the most important really step. and also, of course, protecting the patient's heart. But I think there will be a few where we feel very uncomfortable, all of us, what to do when we are not able to continue, and the patients understandably are very, very anxious about the lack of the ability to continue an effective treatment. And I don't think we have great answers for that.
Sure.
We haven't managed. Yes.
Yeah. So I guess what you're saying, Elsa, is really, like you've been saying a lot of times, good communication between oncology and cardiology to make that joint decision with the patient is very important. And I suppose coming towards the end of our session today, one of my questions to you, Rebecca, is a lot of times the function actually recovers and treatment is completed. What is your, I mean, you're smiling because you know what's coming next. So
I do.
What do you do about the ACE inhibitor and the beta blocker in these patients? I mean, is it the TRED-HF data, or do you stop? I mean, or is it like a personalized approach, as we've been discussing, which may actually be more useful?
Oh, thanks for that one. So I'm not saying I've got I don't have all the answers here. Yes, I have quoted TRED-HF data to patients and to colleagues, and in the past I have tried very hard not to stop medication and have encouraged patients to continue medication indefinitely. And sometimes that's the right thing to do, particularly if you've got a patient who's high risk for whatever reason. I think it's probably overkill for some patients, though. You've got someone young who has no other risk factors. Their ejection fraction is now normal. They've finished all their treatment. They really don't want to take medication for the rest of their life. And it doesn't sit comfortably with me to insist that they continue medication that I've got no evidence base for. So I'm kind of sidestepping the question, I guess. I tend to take a personalized approach and have an open discussion with the patient and say, look, we haven't got any good data here. These are the pros, these are the cons. And then I try and make a decision with them. I don't know whether I get that right every time, but that's what I do.
Sure, great. So maybe
can I ask here? I mean,
sure,
because
yeah.
For the oncologist, obviously, it's important how long do we continue monitoring as well?
Monitoring the ejection fraction, do you mean?
Yes. Yes,
that's another really good question. So I guess if they've only had Herceptin and haven't had anthracyclines, then I'm not normally too worried about long-term follow-up of ejection fraction at the end of treatment. If they have had anthracyclines, which most of them will have done, again, it'll depend on how much anthracyclines they've had, what their risks are. But I would say all of that group of patients should be followed up at least one echo 6 to 12 months post-treatment, and probably every couple of years from then on. But I'm aware that doesn't happen very often.
I agree, but I think, for the oncologists who work closely with cardiologists and get more input, I think this really sits better with us. We feel more confident with this type of care, and I think the patient's more reassured. So I think the message should be passed across.
Great. So I think now an easy question to both of you to end after those difficult questions. So Elsa, if I could start with you, the take-home messages for the audience for this group of patients. What are your take-home messages?
Is it for me, the question, or for?
Yeah, I'll start with you, Elsa, and then I'll ask the same.
Okay. Yes. So I think the most important is a very good baseline assessment of the risk factors, and if possible, really make every effort to have a baseline assessment. Personally, I advise before anthracyclines as well. Definitely for older population, even if they don't have cardiac underlying factors known, definitely echo before the anthracyclines too. Then very good communication with the cardiologist in order to understand better and also be up to date, because I see massive knowledge developed over the last few years. And you also, I think, getting some more up-to-date knowledge in regard to the new agents coming to the market and for use. So having a great relationship and open communication and prompt communication is essential for the patient's care. And I think, working both together, that is the best option for the patient.
Great. I echo all of those thoughts. And Rebecca, your final thoughts?
Yeah, I'd completely agree. I guess the only other thing I'd add in is about the importance of making sure that the drop in ejection fraction is a true drop and not just a variability of the test. But I think the most important thing is the sort of multidisciplinary approach to this, because these are really big decisions that we're making for patients, and it doesn't sit comfortably with me to make those decisions on my own if I'm recommending to stop a patient's chemotherapy or Herceptin. So I think, as Elsa said, communication is absolutely crucial here between cardiology and oncology, and the more cardio-oncology services that develop, I think the more patients will benefit.
Absolutely.
Great. So thanks so much to you, Rebecca, and also to you, Elsa, for this very interesting and fascinating discussion. And I guess just showing how we can communicate between cardiologists and oncologists, and we can find a common language for the benefit of the patient. So thanks so much again for joining me today for this discussion.
Thank you very much.
Thank you.
Really nice. Thank you.